Esteemed members of our community, welcome to this panel discussion brought to you by Cleveland Clinic. As a globally recognized brand with centers in Abu Dhabi, London, Canada, and the US, we are proud to align ourselves with the World Heart Days campaign. Today, we gather here to share valuable information that everyone must know about their heart. As described by the World Heart Federation, World Heart Day is a global, multilingual celebration involving individuals, organizations, and cardiology communities who bring local flair, flavor, and color by sharing heart healthy regional specialties and life saving lessons far and wide. In our pursuit of spreading awareness and knowledge, this year's discussion holds a special significance. Cleveland Clinic heart experts have come together with the alumni of Cleveland Clinic in India who are practicing now here in India to disseminate their vast experience and knowledge to patients and communities who are motivated to learn all about the heart. We aim to empower you with the essential insights that will lead us to a healthier heart. Throughout this engaging discussion, we invite you to learn from the depths of the knowledge that these exceptional experts and practitioners have to offer. So let's embark on this enlightening journey together as we embrace this World Heart Days initiative. Thank you for being here with us and let the conversation begin. Our moderator and host for today's panel is esteemed Dr. Samir Kapadia, who is the chairman of cardiovascular medicine at Cleveland Clinic, Ohio campus. Our panelists for today, in no particular order, are Dr. Ranjit Deshpande, Dr. Dennis Bruemmer, Dr. Vidyasagar Kalahasti, Dr. Usman Ahmad, Dr. Arun Kalyanasundaram, Dr. Pradeep Rachakonda, Dr. Ritu Agarwal, and Dr. Mohammed Said Rihan. And with these introductions, over to you, Dr. Kapadia.
Thank you so much, Deepika, for organizing this, and we are excited that everybody who is super busy is able to spend their time and share their knowledge in this particular event. So with that in mind, I think the most bread and butter part of the cardiology is heart attack. Everybody is worried about having a heart attack. As you hear in the background, there is a siren going on outside of Cleveland Clinic. But the idea is that why is the heart attack preventable? Can we do something altogether and prevent the heart attack? And what are the most important actions? Of course, at different ages, a lot of people have questions when they are younger that they want to prevent heart attack. When they are getting older, they want to prevent heart attack. And more importantly, despite everything we are doing, the trends are somewhat different in India, where heart attacks are happening in younger people at a very rapid rate. So with that in mind, I want to first ask Dr. Bruemmer, who is the expert in prevention and diabetes and cardiovascular disease, who can just enlighten us a little bit about how preventable the environmental factors are that we can prevent heart attack.
Yes, Dr. Kapadia, thank you very much. And Deepika, thank you very much for organizing this and for inviting me, of course. I think as we get older, we start to think about these questions of cardiovascular disease and heart attack much more frequently. I think it is important to recognize that if you look over 1 decade, for example, and this has been shown in many, many studies, many cohort studies, Nurses' Health, Women's Health study, for example, that about 80% of heart attack risk can be reduced by appropriate lifestyle change, not smoking, living healthy and exercising, having a healthy weight, drinking alcohol in moderation, and having a healthy diet. Just these fairly simple steps can protect your heart attack risk over a decade by 80%. Now, so that's the good news. The challenge with this is that often we know about 90% of people do not follow a healthy diet, right? So our society, our lifestyle is not very conducive for maintaining a healthy lifestyle. So I think we really, as a profession and as a society, we need to start to think, how can we implement strategies for people to live healthier? Probably smoking is the most preventable and step in reducing the heart attack risk, even at any time in life. Exercising, of course, as I mentioned, is important. Healthy diet and alcohol in moderation, and keeping a healthy weight. This has been shown in many, many studies. Of course, then we talk about risk factors later on in certain groups of people. We need to introduce steps to assess risk and to treat risk factors in a more specific way. And I think we'll talk about that a bit later. I'll hand it over to the podium.
I think it is great to, so even from the panel of our doctors, how many of us put health as a priority and try to say that, okay, we are going to exercise, eat right, and sleep appropriately, and take care of all the healthy things. So this is, and I'm a culprit myself. So what I'm trying to say is the idea is health is not the highest priority, is the reason why people are not able to follow the lifestyle modification that people understand are very important. Is because they consider their profession as a priority, their family is a priority, their earning livelihood as a priority. So when you are doing all these other priorities in life, health becomes less of a priority. And this is where I think the awareness has to be raised to say that health is a priority. And if you consider health as a priority, then all these things will fall in place. But this is a challenge. This is a real challenge in life that because when you're not sick, you are trying to prevent something for the future. So this is where the challenge comes. So Arun, you can tell us about India, because I know that you are an interventional cardiologist, but really interested in prevention. So what is your insight in the Indian community?
No, thank you so much, Dr. Kapadia. Thanks again, Dr. Ms. Grandhi, for this opportunity. Having had the opportunity to, be in the US for most of my professional life, and then having moved back, I think it's been a very interesting transition. One of the things that I noticed that's a huge thing. I mean, I agree with everything that has been said. With I think Dr. Bruemmer gave a fantastic introduction in terms of risk factors, etc. Couple of things that I've noticed here is that healthcare and the way we access healthcare, it's very, it's very episodic. There is no continuum. And people go to the doctor many times only when they are sick. A lot of patients, and almost every patient of mine, I insist that they have a primary care doctor who manages their risk factors. So it's very interesting. We see a lot of patients that realize that they're diabetic for the first time. During an event. So you have people walking around with hemoglobin A1Cs of 12 and 13 who are being like, oh, I have no problems. But then the next follow-up question is, when did you last see a doctor? It's like, yeah, I have no problem, so I don't see them. India unfortunately has this, reputation for being the diabetic capital of the world. And so there's a lot of patients who, just don't know that they're diabetics. They don't see doctors in a regular fashion because of a lot of other issues, but they just don't have it. And the other increasing trend that I've noticed is, back in the day when I grew up as a kid in India, smoking was taboo and it wasn't really that cool. But now I noticed kind of a disturbing trend in, even the younger age group. You have a lot of people that smoke, and there's a significant number of people that vape because they just think vaping is fine. Smoking, yes, they kind of know smoking is bad, but they don't realize vaping, puts you at a much higher risk for heart disease too. So it's been very interesting. So I think this is very important that we actually put out the message and saying, hey, a lot of these heart attacks are preventable. You are in reasonable control of how outcomes are. And the final thing, and this is another kind of a sad thing in the US, we know that, hey, we can call 911 if you have any symptom that's concerning, right? People don't try and self-diagnose. This is another thing that I've noticed, is that people feel like, oh, I just think it's a heartburn. I know a doctor, so I'm going to call up that person because this is not, I don't think it's a heart attack. People try to self-diagnose a lot. Access to healthcare, even in terms of emergencies, it doesn't always happen in a time-sensitive manner. So, I think these are, some big differences that I've noticed between the West and, India. So Thanks for doing
No,
this.
I think very insightful, and your personal experience, because you practiced so long in the United States and now in India, both, is a very important insight. This raises the question, and maybe Sagar and Ritu can help us to understand that how do you diagnose not just the heart attack, but also the earlier coronary artery disease, and try to come up with an idea that where, and of course, heart attack, if the symptoms happen as Arun was pointing out. But the question is that what is the best way? They should have a CT scan, exercise stress test, visits with the doctors. What are the things that you consider are important for coronary artery disease initial evaluation? And then, of course, how do you diagnose a heart attack and what should we do? Maybe Sagar, you can start, and then we can ask Ritu.
Yeah, so thanks again to Samir and Deepika for having me as a panel here. I echo what Dennis and Arun have already mentioned. So the risk factors are very, very important in preventing the disease in the first place. The second thing is know your family history. I think there are a lot of families that have premature heart attacks in the family, and people may know about it, but they have not really solidified the importance of taking care of themselves based on the family history. And that hits the point that Arun was talking about. So from a classical heart attack symptoms, most people would recognize, chest discomfort. Again, it may not exactly be pain. People describe it in many different ways, where they say it's discomfort, it's pressure, it's, something heavy. I can tell that there's something wrong, but I cannot put it in words. So there are a lot of these different descriptions, but they don't feel comfortable, when they're having this sensation. And most of the times it's triggered by exertion. It doesn't always have to be with exertion. It can, again, happen at rest. So those are some of the important clues to diagnose, heart attack. And again, Arun can attest to this, that, in the US, you have a 911 system to call. But in India, the system is not quite as well set up. But I know there are some big cities have certain numbers that you can call. But I think the problem is that, there is no organized system across the board that can take patients quickly if you're having symptoms. So I think if somebody's suspected of having a heart attack, then the most important thing they can do is probably take 4 aspirins. I think that's probably the initial thing you can do, at least to tide over the immediate symptoms. So I think I'll let Ritu talk to, because she's also an imaging specialist here, to talk about what are the things you can do from an imaging perspective to detect earlier disease, and then what can be done about it.
You need to unmute yourself, Ritu. Unmute yourself. No, not yet.
You're still on mute.
That's okay. You can turn on your speaker. Let me see if I can. Deepika, can you do it for her? Okay, yeah, you got it.
I'm sorry. I'm really sorry. And I was muted.
No, you're not very
okay.
Much. That's fine.
Yeah. So from the imaging perspective, I believe a calcium score is the simplest and the most easily accessible test that everyone can get. And in the practice that I am, we are routinely incorporating calcium scores in the screening packages. That's the first thing that the patient feels that yes, something is wrong. And I personally believe Indians need more of objective data. Like you show them that calcium in the coronary arteries, they kind of have more pressure in their minds to follow the doctor's advice with more strictly. Otherwise, they kind of not see it very well. Now, when I say that calcium score, we all understand that calcium score doesn't look for the non-calcified plaques. So we may still have coronary artery disease, and calcium might be normal, and therefore we also offer the coronary angiograms. So there are multiple kind of packages, cardiac packages, which are available in our institute. At least I know it's not a standard practice, but that's what I'm doing. And a patient comes and gets all the routine blood tests. He gets an echo, a coronary angiogram as a screening package. That's mostly offered to patients who are more than 40s or 50s. and sometimes even earlier if they have some family history, and that helps in picking up a significant amount of coronary artery disease.
It's great. Maybe Dennis, you can reflect on what are the ways that an essential checkup for patient and their family members we should do, because this is a slippery slope in my mind. So the calcium score is a good idea, but there is also one important downside, at least as I see in United States, and also a lot of my patients from India when they call, is that they get a calcium score, they find a little bit of calcium, and then they say that, my God, this is bad, so let's have an angiogram. And then somebody will put a stent in them. And then this is not an uncommon situation, that then they call me and say that, did I really need the stent or not? It's very tough to at that time weigh, and I always say it's okay, whatever is happened, but at least let us prevent the future problems. What are the, let's say if you are 30 and if you have a family member who has coronary artery disease history at the age of 50, what are the things that you would check then is right now in United States to say that we can prevent this problem at 20 or 30, so that at 50 we don't run into the same situation that your dad or your mom ran into?
Yeah, Dr. Kapadia, I think this is a very good comment. I think what you said about the calcium score is also important. In high-risk patients, like let's assume strong family history, let's assume a patient with diabetes, if we get a calcium score, often that provides a false sense of safety to omit treatment that I think is very important. I know this for the diabetic patient population, 1 out of 3 patients with negative calcium score is going to have coronary artery disease on CT angiogram. So I think what is important to consider, we have all the knowledge, we have all the medications, but yet cardiovascular events are going up, right, over the past few years. And the key risk factor that drives the increase in cardiovascular events and mortality is overweight, diabetes, and complications. And as you know, as interventional cardiologists, those patients are the most complex, with most complex disease, with adverse outcomes, poor outcomes. So in the United States right now, I'm pretty sure it's probably about the same in India. I don't know the numbers exactly, but in the United States, about 1 out of 5 teenagers has prediabetes. We have 70% of the US population overweight or obese, and we have half of the US population with diabetes or prediabetes. So if I had a young person that is at risk and has a family history and has any weight problems, the first check that I would recommend is a hemoglobin A1C and a lipid panel. Those are the 2 main tests, I think, because and of course, in addition, we see the patient, assess blood pressure, get the family history. But I think the hemoglobin A1C is one of the most important risk markers that we have right now. And it is also one that we're, as physicians, most inert to, or how often do we see pre-diabetes hemoglobin A1C of 5.8 in patient population, which are actually followed by, for example, primary care doctors, but nothing happens. And that, pre-diabetes is not a benign diagnosis, doubles your risk for heart attack. So I think that there's really a lot of opportunity to prevent and treat. So I would say, in terms of assessing the risk, as Dr. Kalahasti mentioned, I think family history is critical, and probably lipid panel and hemoglobin A1C testing. But then what's more important is for physicians to avoid inertia and actually act upon that. Early treatment.
So just a follow-up question to you is that if you have a prediabetes currently and otherwise asymptomatic, and not obese. And because this is very common in Indian population, to have 5.8, 5.9, even 6 hemoglobin A1C. So what are the different options that they should consider? Because remember that, as you said very appropriately, that there is inertia and maybe lack of knowledge and maybe a little bit of complacency from the physician side to the patient. So what do you recommend that what are the things people should explore and physicians should consider in this patient population?
So, you mentioned an example of patients, you said someone who has an elevated hemoglobin A1C and is not obese. No, that's in the US, that's more uncommon, right? But if you have such a patient, and these people, they fall through any cardiovascular risk assessment tools, right? Because the hemoglobin A1C is not part of the ACC/AHA recommended risk calculator pooled cohort equations, so which I think is a huge oversight. So I would say if you have a elevated hemoglobin A1C, obviously lifestyle recommendations are very important, but I would say the most important medication is going to be a statin, because that will lower the risk dramatically for future heart problems. And yes, the statin may raise the blood sugars, but at the same time, if we have 250 people treated with a statin, one will have a rise in hemoglobin A1C, but we protect 5 heart attacks. So numerically, the benefit far outweighs any risk. So I would say, lifestyle, additional risk assessment, lipid panel assessment, early treatment of risk, and early lowering of LDL cholesterol in these patients.
We can ask our Indian colleagues to say that if you have how frequently people check in India LP little a, or how frequently, because the high so in Indian community, as you probably know, the overall obesity is not a problem, but many times they have a baseline that is increased. They have a metabolic syndrome where they are not, they have high triglycerides, low HDL, and this is not uncommon at all in Indian community. What are the ways in India that people are investigating this population or patients? They're not really patients. These are the primary prevention kind of efforts that we are trying to make. What is the best way? What is your insight, Ritu and Arun, in this particular patient population? Go ahead.
Dr.
So yeah, I mean,
Say-
Ritu, why don't you go first, and then I'll just add on. Yeah, go ahead, please. Yeah.
So I think so for this particular group of patients, a regular follow-up should be more important. And lifestyle modification goes a long way. It's more of a clinical question, so I would just ask Dr. Arun to add.
So yeah, I mean, I do check lipid small a occasionally. I mean, especially in young heart attacks. But the key is, like, once they've had it, when it comes to secondary prevention, I don't know necessarily the treating it. I mean, I'm still going to use the same armamentarium in terms of treating, right? You're still going to rely on your statins, the occasional PCSK9. No, we have bempedoic acid. We have a few other options, but essentially in terms of treatment, I don't know if necessarily treating that makes a big difference. In terms of primary prevention, no, I mean, I don't see a lot of patients for primary prevention, so I don't want to say this, what is being done in general practice, but as far as I can see, very few people come to me with those values. Likewise, I completely agree with what Dr. Samir Kapadia said in terms of there being truncal obesity. There's a lot more visceral fat that we see. Triglycerides are often high. HDL is notoriously low. Yeah, I mean, so we have this metabolic milieu, and I think amongst the Indian population, which just puts us at a much higher risk. Of course, I mean, there might be other genetic polymorphisms that put us at a higher risk for coronary artery disease. Yeah, I mean, and overall, I think this is one of the interesting things that I've noticed is that, you know, growing up, there's not a lot of emphasis on physical activity. We don't move as much as I think we should. We try to compensate for it later on in life. So I don't know if necessarily like just increasing your overall, you know, number of steps that you take or just being more active in general might help offset some of these metabolic syndromes, so to speak. I'm also kind of curious, and maybe Dr. Bruemmer or Dr. Kapadia or Dr. Kalahasti, one of you guys can add to this. You know, we do have statins. I think a lot of people are on statins. Do you guys, like, let us say in the pre-diabetic population, if they're not obese, I mean, obviously we're going to start with lifestyle modification first. Do you have a lower threshold for initiating, let's say, drugs like metformin, etc., early on? Do you guys recommend that? I mean, I guess that's probably a question for Dr. Bruemmer.
Yeah, I think so. Maybe before answering this question, I may have one comment on the Lp(a), which Dr. Kapadia mentioned. So what we recommend here at this institution and most of the US is to obtain an Lp(a) level in a family history. Okay, when a patient has family history, particularly premature coronary disease. And we then actually treat the vast majority of people with statin plus aspirin. Because of the prothrombotic activity. So, and oftentimes the Lp(a) is positive in 1 out of 5 people in the general population. And oftentimes this is exactly the family where there will be a history of premature coronary disease. So the second question, yes, it's all about starting early, right? You want to protect atherosclerotic plaque formation over a lifetime. And we know in patients who have early risk, there is early plaque. We've known that from many studies. So I think, you know, whether here patients at risk for diabetes should be treated with metformin, and this is not frequently happening. Now, whether metformin specifically reduces cardiovascular risk is not well established. It reduces the progression from pre-diabetes to diabetes, which then in the second step may protect from cardiovascular disease. But again, I think there is no better way to protect from coronary plaque development other than lipid lowering and LDL cholesterol lowering. So if we have someone who has an increased risk, Lp(a), hemoglobin A1C, family history, low HDL, I think the key step is to lower the LDL cholesterol.
No, very well put. Sorry, please.
No, I was going to ask the same question that Arun brought up, you know, because the traditional South Asian or Indian gene, you can think about it, you know, they tend to have a lot of hepatic fat deposition, you know, so I think, you know, one of the ways that metformin may potentially, you know, act on that, you know, may have a role to play. But again, the aversity to taking a medication may be a barrier too, right? People who don't want to take a medication. And again, these medications are something that you have to take lifelong, right? So I think that's definitely a factor. The other thing that Arun brought up earlier on is that I think the combination of this metabolic syndrome gene or profile and smoking, I think it's a deadly combination. And you know, and the amount of, you know, I mean, I visit India now more frequently than what I did before, but there was a gap of 6 years when I did not go to India. And between those 6 years, the amount that I'm walking on the streets, whether it's in Mumbai or Hyderabad, wherever, the number of people smoking, men and women, has exploded. It's like everywhere. I mean, you cannot walk more than like 100 feet and then you don't get the smoke outside in the environment. So that was like, for me, it was a staggering and a shocking development. And I think that's definitely a public health campaign about smoking would also go a long way in reducing the risk of having the first MI.
No, I think very important point. One just a comment that a lot of cardiologists make to me that they don't see patients for primary prevention. I think this is not a good response, because when you see a patient who is having a heart attack, you have the whole family, they're older people that you got to influence. you have to tell them that, listen, you got a heart attack. Now, how many kids do you have? How many brothers, sisters do you have? So you have an opportunity, huge opportunity to impact primary prevention. So every time, at least I see a patient who is young or even old, and I always ask them that how many, not just for their family history, but to help the family members. So this is a very important, I think, a message that you can send out, because you are right that a person walking on the street who is healthy is not going to come and see a busy cardiologist. But if a busy cardiologist reaches out to them to say that, okay, why don't you ask your colleagues to check your cholesterol and hemoglobin A1C, and if there is a problem, please reach out to me and I'll help you. This I think goes a long way in managing the primary prevention in the community. So I think this is also an important message from my side to the cardiologists, that please do that. It is I know that everybody's super busy, but this is an important part of our duties. Ask Ranjit and Pradeep, because we have not yet involved them in these discussions, to say that what are the ways that people have the cardiologists, cardiac surgeons work together and say that how we decide what is the best way to do revascularization or any other therapies that require surgery or intervention. What should people know about this to say that what is the best way to provide, get care from a good heart team approach?
You want to go ahead or do you want me to talk?
Can I take this initially?
Yeah, sure. Go ahead, please.
Thank you, Dr. Kapadia, for the question. So, yeah, I'm a cardiac thoracic surgeon based at Hyderabad, India, and it's a pleasure to interact with all of you. So, to answer your question, I think at least I can talk about what we do here in this hospital. So every patient after the angiogram, we kind of sit together with the patient. If there is a classic case for surgery like triple vessel disease or a left main and all that, usually gets referred to a surgeon. And for some other patients who have a single vessel or double vessel disease or calcified lesions, still the surgeon gets involved with the cardiologist, and we try to talk to the patient together, like the patient, the cardiologist, the interventional cardiologist, cardiac, we all sit together and decide. And we have started to offer more of a minimally invasive bypass where we do the left thoracotomy and we do the lima to the LAD graft. And when feasible, we do multi-vessel, but most times we try to do hybrid revascularization for patients who have a double vessel disease and all that. If it's very calcified or classic triple vessel, then straight away they come to the surgeon. And so, but every patient, we decide based on each artery, and like this will be the plan for the lady. The circumflex, if it's moderate disease, we'll have medical management. The RCA is diseased, then that will have a PTCA. Like we decide for each patient based on the vessel, and then it will be a heart team. Though it is not always easy, this is the first center where I am working in India where we follow that. The earlier centers, the patients hardly see the surgeon. Like sometimes they were unscrupulously stented, and there are another set of cardiologists where like even single vessel disease we ended up doing bypass. And so we see all sets of doctors, and that has been my experience here so far.
And I kind of agree that one of the most important challenges is to have a doctor who is really interested in the well-being of the patient rather than the business. I always tell people that people come to Cleveland Clinic is not because we do good business, but because we take good care of patients. So the business, unfortunately, is not the primary goal of medical treatment. And it is very, very difficult to separate this in real life. We are lucky because we are fortunate that we have enough resources individually and institutional wide. But if we had to worry about the business, then it becomes extremely difficult because the priorities change. And so for one of the suggestions for the patients, I always tell them that you want to go to busy people because at least that way they are not interested in doing things to you that you absolutely do not need, and the business is not a super high priority. They are trying to do the right thing, so the business will come to them. Of course, everybody needs to be accountable and do business, but this is a challenge in a very competitive practices in India, where the business sometimes take precedence over practice of medicine. So this is an important message that working as a heart team is super critical as you are doing, and of course taking care of anatomy and patient factors. So this is also very important to keep in mind that in cardiology these days with imaging advances, people are so focused on anatomy, but patient is not an anatomy, right? So there are so many different things that are happening to the patient, social level things. So you have to put all these things together to decide that what is the best treatment. So many times reviewing a study, reviewing the images is not a good idea to give an opinion to say that this is the best thing or not. You got to see the patient and discuss the patient. So again, see the doctor, don't just go by the opinions based on the review of information. This is one of the important messages, at least I think we have to have. Ranjit, you have anything to add?
Yeah, hello everyone. Thanks for inviting me for this. It's a great pleasure. I met Samir at Cleveland Clinic London. I'm sure I'll meet all of you later. I have had the advantage of training in Mumbai actually and working for 4 years in the private practice there. And then I came to England. So I can relay with Pradeep what he's saying. What I gathered was that if you are present you can't be present as a surgeon for every angiogram, but if you're asked to cover an angiogram, and if you're there, this is what my personal experience is, that when I started my practice, when I was just trying to get more and more work, I used to be there. And as a surgeon, if we can, I mean, we can't be like interventional cardiologists, but if we can speak the language, if you're on the same wavelength, if you understand what's FFR, what's IVUS, all those things, then there's a mutual respect amongst two specialties and they know exactly what we're doing. The second thing what I realized is right from the outset, 20 years now, I took the ownership of doing a lot of arterial grafting. And I think all cardiologists respect the lemur. And King's is known for right mammary artery as well. The second thing is in England, so this is in the NHS, but in England, one thing good is if it's a straightforward like mid-vessel LED, you can go and stent. If it is double vessel, mid-vessel, that's fine. But if it's a triple vessel disease, then the insurance company will not cover you unless the patient has been discussed in MDT. So even if a cardiologist wants to do multi-vessel PCI, they will not be covered. And that's what we have started at Cleveland Clinic London also. Tuesday morning and Thursday evening at 5 o'clock, we have a MDT where you can discuss valve cases, you can discuss coronary cases. And that is amazing. And sometimes we actually have a patient waiting outside. So patients love it. When you tell them that we are going to discuss your case as a joint meeting, they think that they're given a lot of importance and they love it actually. So maybe Pradeep, if you can start this at your hospital, having regular MDTs, I can understand if it's a left main stem or ongoing angina, but if somebody can wait, one thing, Samir and everybody, I think a lot of your colleagues must have seen the Indian population, I think maybe in the US also, everybody wants it done immediately. Like, you have triple vessel disease. So my friends who come from US, they can't understand how I have a waiting list going on to October for a triple vessel disease waiting for CABG. But we have shown that in UK actually, people don't die on the waiting list. You need to triage them, you need to prioritize them, and that's the same thing in India. And I think in India, I'm sure that this morning only I had 2 phone calls from Mumbai. I think they must be seeing on a regular basis 2 or 3 cardiac surgeons and cardiologists before they come to you, Pradeep, isn't it? They must be taking lots of second opinions. But maybe
Yes.
arterial grafting, minimal access surgery, which Pradeep said, is very important. And talking the language, the same wavelength with the interventional cardiologist has helped me to develop my practice. So I don't, sometimes, for example, FAME3, or sometimes you talk about Syntaxco. And, you know, it's okay. Maybe let them do multivessel PCI for a straightforward lesion. But then if it doesn't work, it'll come back to you anyway. So you haven't burnt all your cards. And that is my theory. And that's where I talk to the patients as well.
So
Very insightful. And I agree with you that somehow tying the payment to multidisciplinary team has worked even for Tower in the United States, the same concept that you have to have a surgeon and a cardiologist. So financial incentives have to be aligned for people to kind of follow the guidelines.
Samir,
Comments? Yeah, go
is
ahead.
it okay? I just wanted to get, I'll just be brief. No, excellent points. And I completely agree with what you just mentioned about, like, you know, getting second opinion from people who actually do a fair bit is important. The problem in India that I've noticed in the last couple of years is that it's not just second opinions. You get second opinions, third opinions, fourth opinions, and everyone has an opinion. You will ask opinions from like, oh yeah, I know this doctor, so your orthopod will have an opinion. Everyone has an opinion. So, you know, one of the things I tell people is, hey, if you want a second opinion, get it from these guys because these are good people. They, you know, they're going to do what's right for you. I think that's important. The second thing is, you know, it's not even you know, a battle between interventionalists versus bypass surgery and multivessel disease. A significant number of people are undertreated because they're just told that, hey, we can cure you. I never use the word cure, by the way, and I think most of us don't, right?
Yeah.
I'm going to cure you with, you know, with something like with medications or with EECP and, you know, everything. It's like I literally have somebody who, you know, who has a board saying cure heart disease without surgery. I mean, it's actually right there in the, you know, outside. So, you know, there's a lot of information and a lot of misinformation out there. And I think that is a huge challenge that we face, you know, practicing here, because you're not really, it's a significant number of people that are being undertreated. Oh, you're 50, you can live with angina. It's okay.
Let me ask, I introduce you to Dr. Ahmed Usman. So, you know, he is our very leading thoracic surgeon and also an expert in lung transplant. So one of the common things we see, Usman, is that these days people have a lot of CT scans and things like that, and then they find lung nodules and sometimes important pathologies. What do you suggest? What is the most important role of a thoracic consultation and pulmonary and thoracic, pulmonary specialist and thoracic surgeon working together? What is the best way you see this happen? And you are, of course, in Abu Dhabi and, you know, and work extensively in the United States. So you may have some insight for the region to say that what are the most important differences and how should we practice?
Thank you, Samir. Thank you, Deepika, for putting this together and inviting me. This has been enlightening listening to all of you. It's good to see old friends and hopefully new friends soon. You know, a lot of comments here. You know, if we just step back a little bit, take a 30,000-foot view, we are sharing experiences from 3 different continents at the moment, which is quite unique. And this is the strength of a multidisciplinary team. This is why Cleveland Clinic is Cleveland Clinic and perhaps Mayo Clinic is Mayo Clinic, or why expertise that is shared across specialties and across now continents can help make the right decision for every patient. So before I proceed to your question, and I'll just echo what Arun just said. It really hit home. We've been exposed to different patients in different strata of the world, and we see different socioeconomic problems, behavioral issues that come with disease management, and psychological issues. But this whole issue of second opinion takes a new life of its own in the part of the world where I am. And people would come to you with letters from doctors who I would not send my dog to, but they want to get a second opinion from them and then come and show it to us or people like you and say, okay, this is what I want. No surgery, but I want my heart disease cured or my cancer cured. Or I'll just have hummus and tahina and my cancer will go away. So those kind of challenges, I think we all have to continue to face and educate and so on and so forth. One of the things that I see that is in your domain, and again, I'm sorry I'm deviating from your question, but I thought it was important, is that there's a lot of influence of bariatric folks now in preventive heart care, and that seems to be a movement that is taking form without an adult in the room. And I think that's where you guys have to step in, and perhaps you already have, and the ACC already has, to guide this conversation. Because to me, it sounds like it's just going on without any critical supervision. And people are getting these surgeries or procedures willy-nilly to modify their cardiovascular risk. So anyways, I'll leave that for you guys to mull over and then think about and perhaps address. But as far as your question goes, so the conversation that we've had in the last 45 minutes has revolved mostly around risk assessment. And that concept applies to lung findings also. So obviously, what we worry about in the lungs when we see an abnormality, the biggest fear is a malignancy or a cancer. And we have to take every CT or X-ray or MRI or PET scan abnormality and put it in the context of that patient's individual degree of risk. A 30-year-old with who's never smoked and has a healthy lifestyle and has a 3-centimeter solid nodule is a very different problem from a 70-year-old 30-pack-year smoker, and both need to be worked up accordingly. And this is where, again, a team of experts coming together to assess every one of these situations is important. So there's a lot of CT screening going on around the world, particularly in smokers. But if we go back and look at the National Lung Cancer Screening Trial, the guidelines clearly recommend that any CT abnormality that is discovered has to be evaluated by a multidisciplinary team before a biopsy or a surgery is attempted, to minimize the risk of or the chances of unnecessary interventions. So those concepts apply everywhere. I've been here a year now, and before I came here, I was told that there's no lung cancer in this part of the world. Now I find hard to find time in my OR schedule to book cases. So it's just a matter of educating people, creating the right programs and the right setups. We deal with some, I think, from in different places in the world where we are, there are some unique diseases and presentations. So the presentation of lung cancer or pulmonary fibrosis or COPD is very different in the US versus the Middle East or in Southeast Asia. But again, lung cancer remains our biggest foe. Our threshold to intervene or to kick off the workup should be low. So if you guys do a coronary CT and see something, say something, do something. I think that there's a lot of awareness about that in the cardiology literature and community, and that's fantastic. The other issue but point I'd highlight is that there are differences in the genetic makeup of these populations. So to give you a quick example, as much as the Middle Eastern population smokes and various types of smoking, not just the regulated tobacco and cigarettes, and their exposure to silica from the sand is very different from what you would see in India, Pakistan, or the US. Despite all of that, the incidence of emphysema or COPD is extremely low in this part of the world. So I have not seen a single COPD patient that is of Emirati origin or Middle Eastern origin. I've seen COPDers and I've done transplants on them in the UAE, in Abu Dhabi, but they were European expats who were smokers and have been living in the UAE. So there's clearly genetic differences. We're seeing a lot more esophageal cancer at a much younger age in this part of the world. Coronary disease is through the roof. It's just a different beast altogether. I think our colleagues who practice in India and perhaps England perhaps see that also. It's a similar sort of epidemic type of itself. So in any case, that was a long-winded answer to your question, which was CT abnormality, which again has to be evaluated in a multidisciplinary fashion. So when someone calls me, say, you know, what should I do? I have this problem. The answer is what you guys just mentioned a few minutes ago. Hey, go to a group of people who know what they're doing and whose opinion you can trust. And typically, when you get to a place where you have brain power like we have in this call right now, you'll generally walk out with a reliable answer.
One important question I also have is that how accessible is Abu Dhabi for Indian and Pakistani patients? Because it's as close to as going from one city to another, in my opinion, in India. So this is a very important resource that people have, and maybe people don't understand and know enough about this hospital. So you may have some insight into it since you have been now working there also in Abu Dhabi. That what is the best way to even contact some second opinion or whatever you call the opinion in Abu Dhabi?
Yeah, thank you, Samir. Great question. So we are a full service hospital. You know this. You've been involved in creating the place from day one. But just to put things into perspective, people don't know about Cleveland Clinic Abu Dhabi enough, but we're a multi organ transplant center, and that's what we're known for right now in the region. So in a 6-hour flight radius, there's no other place, including Southeast Asia, that does things at the magnitude of what we're able to, well, we have the privilege of doing here. So we're a heart failure, heart transplant program, lung failure, lung transplant program, liver, kidney, pancreas, all of it is up and running. This year, we're probably going to do close to 100 liver transplants, probably close to 15 to 20 double lung transplants. And the heart transplant program has been also reinitiated and reinvigorated. The UAE government is very uniquely progressive. The UAE population, as you may know, is only 10% Emiratis. 90% are people who look and sound like us. It's a mixture of everybody from around the world. And they take that into account very smartly to say that, listen, we're going to open these services to people from all these countries. So by the same token of this mixture of population, most of the donors in this country are from other countries. You put that in the equation, and the government is smart enough to say that, listen, if your donors are from all these countries, why restrict transplant access to Emiratis only? So you can actually come into the UAE and get cancer care. You can get transplant after going through the selection process, obviously, and all other care. So complex cardiac care, thoracic surgery, robotic surgery, all solid organ transplants are fully available, accessible. Obviously, the cost is a fraction of what it would be in Europe or North America for a South Asian patient. So we're very uniquely positioned in that way to have real, true North American healthcare presence in this part of the world.
I think we are coming very close to the end of the hour, so I want everybody to just comment on whatever they think is that I may have missed and we didn't cover. So we can start with Ranjit. Thank you again for joining from London. It was great to see you there, and I know that how busy and skilled you are to spend this time with us. So Ranjit, you can just start from you, and then we'll go in one by one to have the last few words.
Well, thank you for this opportunity. So basically at Cleveland Clinic London, which I think we're the most recent place, and the team is fantastic. It's very strategically. Samir, you've been there, and I think some of you most welcome. So I'm there on Thursday and Friday, but we do, except for heart transplant, we do everything possible. TAVI, multivalvular, edge-to-edge repair, minimal access cardiac surgery. We have a robot now, minimal access CABG, minimal access aortic valve replacement, repair. So we are 6 surgeons, about to appoint a 7th one. and we have lots of cardiologists, a lot of atrial fibrillation work. We've been blessed by some people from the main site as well. And it's superb for me to work there because I used to work in other private hospitals in London. But here I feel like I'm in a team and the support is amazing. You know, you need an anesthetist, you need an OR, you need a cardiologist, you need an EP. You will find them within no time. And in fact, it has helped me to increase my profile back in India as well. My father is 88, he's still a practicing GP in Mumbai. And I have a lot of connections with Mumbai. I do get invited. I think people like Pradeep invite me for, and I always seek the opportunity to go there on basis of Cleveland Clinic as well as King's College Hospital as a faculty. And that also I learn a lot from. Miss India is progressing like really rapidly, you know, and I learn a lot from that meeting as well. So yes, I think it gives me tremendous pleasure to join this huge community. And you know, the aim is provide the best patient care which we can in whichever way possible. You know, that's what I say, Samir. And I think I missed out your beginning part, which was quite interesting, actually, prevention. And Arun and Dennis and everybody said this. But if I can be of any help in the prevention program, also giving lectures or what it is for future of cardiac surgery, I'll be more than happy.
Wonderful. And Dennis, if you have a few last comments.
Yes, thank you. So first of all, thank you Samir for putting this program on. I think it's been a real pleasure, and I think it represents what Cleveland Clinic is, a multi-specialty group and collaborative approach. And when I came here, you know, I had interest to provide better care for our patients for diabetes within the cardiology community, where there's a lot of need, and often we in cardiology, we do want to facilitate care, and we do want to provide excellent care. So this institution has certainly had a lot of interest in building a cardiometabolic program, and we have all the tools, we have all the medications. It's just been very difficult in general to apply this knowledge to the broader population, and I think this is what we're doing, particularly with respect to diabetes care in collaboration with imaging, with intervention. So it's been a really great pleasure to be working with everyone, and I think we do really begin to leave a mark and affect patient outcomes. So, and there's a lot of potential to do similar things around the world, where cardiologists work very closely with endocrinologists and cross-bridge towers, so to speak, to jointly improve care for the largest patient population that we see in patients with cardiac disease is the diabetic population. So I think I'd like to thank everybody and allowing me to participate. So.
Wonderful. Pradeep, you have a few comments.
Yeah, thank you, Dr. Kapadia. It's been a pleasure and privilege to interact with all of you, giving me nostalgic memories of Cleveland Clinic, my days. I just wanted to reiterate one point Dr. Samir said at the start of the session. We don't make healthcare a priority till we lose it. We give priority to the career and family and all. So I feel the average age of CABG that I do here is like around 45 to 55 nowadays. It was around 65, 70 when 10 years ago when I did my MCH, and in the Cleveland Clinic it was also 70 plus most patients when I did my fellowship. Nowadays it's 45, 50 routinely every week. We are doing CABG. So I think healthcare has to be a priority, and that message has to be drilled deep into the public. And I think Cleveland Clinic being in a position of power, I think they can mobilize resources, and it doesn't apply only to India, but I think most part of the world, coronary artery disease is an epidemic, and I think it's a slow epidemic. So healthcare has to be a priority. It has to be made a priority, and that message has to reach the general public. That is what I would like to say. Thank you.
Well, Arun?
Okay, I have a lot of things to say. I'm going to be fairly quick. So first of all, Thank you so much, Dr. Kapadia. Thank you, Deepika, for having me as part of this panel. I'm honored and privileged to be part of this August panel. I actually do want to take a second and thank Dr. Kapadia. I still remember the phone call that you made and said, "Hey, Arun, would you be interested in joining us?" So I'm incredibly thankful to you for having set my career in a trajectory that I otherwise would not have had. So thank you again, and for all the teaching that it's been fantastic, truly an honor. From there to now being like the Asia Pacific CTO Club Director for India, it's been a long road, but I'm incredibly, thankful for that. For patients, and again, this has been a great group. Thanks for introducing us to each other. I think we're going to have a lot more interactions. It should be fun. For people that are watching that are non-medicos, a couple of quick things. Don't ignore symptoms. If it's a new symptom that's bothering you, please seek medical attention ASAP. Don't wait for your doctor. Number two, focus on prevention. I think it's critically important. Get reliable second opinions. And I think, Dr. Kapadia summed it up beautifully, and I think Pradeep just did too. Make your health a priority because you just get one life to live. Unless we get philosophical. So make the best of it. Thanks.
Thank you again. And Ritu?
Yeah, I would really, it was an honor to be here, and it was great seeing you, Dr. Kapadia and Dr. Kalahasti. I kind of remembered the readings we used to do in the reading room together. And obviously, being a fellow at the clinic had definitely changed my life. I am on a different genre now. So that being said, I'm in a corporate practice and kind of establishing cardiac radiology. Our chairman is a cardiologist in US, so I kind of had a structure, but um, cardiac imaging is not that available here, especially cardiac MR. So my focus had been on developing cardiac MR. Like when I was a fellow, I saw like almost every patient getting an MR. Nobody ever missed out, but here like cost is a major issue. It's like a cardiac MR costs around 16,000, which might be a very few dollars, but in India, it's like hard for the patient to convince that. It's sometimes even harder to convince the cardiologist on why why your patient should spend that amount of money. For viability studies, most of them are convinced, but for other things, we are slowly picking up pace. So we are far behind the clinic. I agree to that, but we'll be there someday. And thank you so much for having me.
Wonderful. Sagar?
Yeah, thanks again, Samir and Deepika, for putting this together. It's wonderful to see folks from, as Usman had mentioned, from 3 different continents and talking here today. I think we spent a lot of time on coronary disease and everything, just to keep in mind that there are multiple other parts of the heart that also, if somebody gets a valve disease or an arrhythmia or heart failure or something, there are also specialty doctors who are involved with that. And again, the same points are valid there too, with regards to valve disease. Get a second opinion if somebody is telling you to have surgery sooner or later. So I think it's the same multidisciplinary team concept. I think that's very, very relevant for other aspects of cardiology care. And I think all of us are hit on the point about prevention. And I think you have to become selfish about your own care, right? And if we don't take care of ourselves, nobody's going to take care of you. So it's always very, very important to re-emphasize that message that take time for yourself, and if you take time for yourself, your family will be happy too. So it's important to keep that in mind. Thank you again.
Wonderful. Thank you again. And Usman, we finish with you because you are the leader there in Abu Dhabi. So we want to make sure that you give us your final word for this nice symposium.
Thank you, Samir. The final word is from the group, but I'll just say that it's been a pleasure seeing everyone, and I really look forward to inviting all of you, hopefully hosting all of you in Abu Dhabi. So the Cleveland Clinic promise is patients first, and that is what we stand by. That is why we come to work every day, and that is what we work hard to uphold. Now, for those of you on this call, physicians listening or patients who might be interested, we are in London, we are in Abu Dhabi, we are in Florida, and we are in Ohio, which is our main campus or mothership. whatever you need, particularly if someone is geographically located in India, all you need to do is to let Ms. Deepika Grandhi know. She has all of our phone numbers, and she is not shy to call us at any time of the day or night. So getting us, finding us is never a problem. We truly believe in multidisciplinary team approach to every disease in the body, be it heart disease or something else. And if you get the opportunity to be part of a team like us or be exposed to the teamwork, you'll get to see that firsthand. It's been a pleasure working with those of us who have worked together. We know that at a drop of a hat or one phone call, the other person is standing next to you without asking any question, with the priority of taking care of that patient's problem. So that is our promise to the patients, that you will get the best of the Cleveland Clinic experience at any one of our hospitals or campuses. And it is a privilege for us to be involved in your healthcare. So thank you very much. And Deepika, thank you again for putting this together.
Thank you, all of you. And it was wonderful. Deepika, we cannot do anything without you. So thank you with the most sincere thanks to you.
Thank you so much, everyone. As a patient advocate, I have no doubts in my mind that this information that was shared by the esteemed panel will certainly help contribute to reducing the cardiovascular disease across the globe. I'm still in awe of the geographical spread and knowledge of our panel today. We have the collective best practices from India, Middle East, UK, and US. So again, I appreciate everyone for their time, and especially Dr. Kapadia for accepting to moderate and lead this session for us.
Thank you. Pleasure is all mine.